one by one, starting off with the stomach, 4-chamber, 5-chamber. I can put that in practice. I'll just now show you abnormalities that you can see in each of these sections, one by one. So if we look at the stomach, if you go to work tomorrow morning and you examine this baby, you appreciate when you look at this that the right-hand side is here and the left is here, and the heart is on the left-hand side. But if you go back to the beginning of the flip, you see that the stomach is on the right. The heart structure looks normal. It's not a structural abnormality, but the heart is on the left and the stomach is on the right. So this is a baby who has got atrial isomerism. And it's very important to make this diagnosis because many babies with atrial isomerisms will have a single gene disorder, a monogenic problem. And therefore, it's very important when doing a scan that you split your screen demonstrating the stomach and the heart on the same side. So this is the first example of an abnormality on the first section. In this baby, you see that the aorta and the IVC are side by side. Normally, the aorta is to the left of the spine and the IVC is anterior and to the right. So this baby is abnormal. And you see this before you even look at the heart, you realize there is an interrupted IVC with azygous continuation. That's the most likely explanation as why the aorta and the IVC are side by side. An interrupted IVC with azygous continuation is a feature typical of left atrial isomerism. And the first clue is by examining the abdomen. In this baby, the stomach is on the left-hand side, and the gallbladder is next seen, and then the intrahepatic vein curves towards the stomach. This is abnormal. Normally, the stomach is here, and the intrahepatic vein curves towards the right, and the gallbladder should be here. So it should be stomach, intrahepatic vein, and gallbladder. But this baby is stomach, gallbladder, intrahepatic vein, reverse curvature. This is a baby with a persistent right umbilical vein. And it's important to pick up persistent right umbilical vein because a significant proportion of these babies will have a cardiac abnormality. Now I want to ask you a question. When you go to work tomorrow morning and you scan this baby, what do you think is the problem? Number one, you see the transverse section through the abdomen, and this is the baby's stomach. It's on the left-hand side. It looks normal. But the intrahepatic vein does not curve to the right. The intrahepatic vein goes straight through and drains into the IVC. What do you think this problem is? This is a baby who has an absent ductus venosus. And we pick the abnormality up because we can see the abnormal course of the intrahepatic vein going straight in and draining into the IVC. Because this baby has no ductus venosus. Normally, it comes in like this and gives off the ductus venosus. But this baby is abnormal. What do you think is the abnormality here? This is the cord insertion into the abdominal wall. And this is outside the baby's liver. And you see a varix. It's more than 8 millimeters. And you need to check these babies because they can rapidly dilate. And if they rapidly dilate, they are associated with increased fetal death in utero. This baby also has a varix, but this varix is different. The varix is actually intrahepatic. Intrahepatic varices are much rarer. So that's the first section. The next section is the important section of the fourth chamber. This is the descending aorta, left atrium, left ventricle, and there is no right ventricle. This baby has got a hypoplastic right heart at 13 weeks of gestation. If you want to, you can see much clearer images of the baby with the high frequency transducer. This is the descending aorta, left ventricle, right ventricle. This baby has got a hypoplastic left heart. So in a 4-chamber view of heart, you can appreciate a hypoplastic right heart and a hypoplastic left heart in the first trimester of pregnancy. Just like the case that we saw yesterday with the hypoplastic left heart at 13 weeks of gestation. This baby is not a complete hypoplastic left heart. It is just the left ventricle is smaller when compared to the right ventricle. And any time you see this, you need to consider a number of diagnoses. The most common explanation is coarctation of the aorta. Then next, interrupted aortic arch. Next, mitral stenosis with VSD. And you know it's the left ventricle because this is your descending aorta, which is on the left side of the spine. And therefore this is the left atrium and the left ventricle. Remember my golden rules. This is the descending aorta, which is to the left of the spine, normal. Left atrium. And the left ventricle is dilated. So this baby, the left ventricle is small. This baby, the left ventricle is enlarged. This is a typical feature of critical aortic stenosis. And this baby is at 18 weeks. When this baby gets to 32 weeks, there will be a small left ventricle. So first, it dilates with fibroelastosis, and then as the pregnancy progresses, the ventricle becomes smaller, and you end up with a single ventricle. But these are examples of a small left ventricle and an enlarged left ventricle. On the 4th chamber, you may also appreciate that the right ventricle may be small. So this is the right cardiac ventricle, descending aorta, left atrium, left ventricle, and compare the size of the right and the left ventricle. And you will see that the right ventricle is small. You see the chamber, the size of the chamber of the ventricle is significantly smaller. This is all muscle, but the ventricle is small. This is the baby with pulmonary atresia with intact ventricular septum. Sometimes that can be a difficult diagnosis. The other possibility is critical aortic stenosis or tricuspid atresia with VSD. This is the baby where the right ventricle is enlarged, descending aorta, left atrium, left ventricle, and the right ventricle is dilated. And you compare the sizes. Now you ask, why is the right ventricle dilated? And if you look here, at this point from here to here, that there's a bulging of the right ventricle in the baby with a cardiac diverticulum. This is a serious congenital abnormality. The other causes as to why the left ventricle and right ventricle may be discordant in size, with the right ventricle being enlarged, is total anomalous pulmonary venous return. So remember, there are two conditions that may look very alike: total anomalous pulmonary venous return and coarctation. Because in both of these, the left ventricle appears small and the right ventricle appears large. And then you need to look for the features of both of these. But this baby has a diverticulum. The other causes are Earl's disease. You'll get fibrotic change in the right ventricle, cardiac aneurysm, duct constriction, and as I mentioned, absent pulmonary valve syndrome. So if you look at this baby, you can see very straightforward with a high frequency transducer of 9 megahertz, which is a very nice probe in this ultrasound system, because I can see the VSD without using the need for color. I could not see this VSD the RM7C or the C2 to 9. This baby has got a VSD here. This is a much more difficult view to see. This is a muscular VSD, this is an inlet VSD. And we scanned yesterday a baby with an inlet VSD. There are three things that you look for in making a diagnosis of the VSD. Because sometimes you can make a false positive diagnosis. You need to be careful. But the first thing you see, number one, is dropout in the ventricular septum. The second thing you see is a hyperechogenic foci. And the third thing that you see is a wash of colour from left to right side and colour doppler. You need to see these three things to make sure that we're not making a false positive diagnosis of an inlet VSD. In this baby, when you look here, you see there's a defect in the atrial septum. Normally, the atrial septum, you see the AV valves, and here is the interventricular septum. Is the tricuspid valve, which is a little bit lower, and then this here tissue is called the atrium primum. This atrium primum here has got a defect just at this point here. And when you look with an atrium primum septum defect, the flow will be from the right side to the left side on colour Doppler examination. If you look here, it is blue. It's going away from the transducer. But a baby who's got a dilated coronary sinus, the flow will be in an opposite direction, from left to right, and you can appreciate that here in this baby. In this case, the baby with a four-chamber view of heart is the descending aorta, left ventricle, right atrium. When you look at the ventricle, you can see there is fibroelastosis. But when you look at the valve, the mitral valve, and you turn on color, you will see that there is a regurgitant jet that is hitting the roof of the atrium. This is a typical finding of aortic stenosis, critical aortic stenosis. This is the baby, the descending aorta, left atrium, and therefore this is the right atrium. And you can see a regurgitant jet, which is mild tricuspid valve, blue. Because remember, always set this at red. So inflow is always red, and tricuspid regurgitation is always blue. And that's a blue regurgitant jet. 5% of pregnancies have got tricuspid regurgitation, and it's a normal variation, which you need to classify whether it's mild, moderate, or whether it's severe. When you look at this baby, this is mild regurgitation or trivial regurgitation. When you look at the next case, it's severe regurgitation, that the origin is deep inside the right ventricle with enlargement of the atria and a severe regurgitant jet in a baby with Epstein's anomaly. This is a baby, when you look at the heart and you draw a line through the center of the heart, one half of the heart on the right chest and the other half of the heart is in the left. You also see that the aorta is not to the left of the spine. The aorta is centrally sitting over the spine. And this is the first clue of mesocardia. You also see, when you look at the descending aorta, the left atrium, the left ventricle, and this here is a small right ventricle. So there are several problems with this baby. Mesocardia and a hyperplastic right heart. In this baby, when you look, the aorta is to the left of the spine, but if you look at a line through, the axis of the heart is rotated to the left. This is 90 degrees. The normal heart is 45 degrees, plus or minus 20 degrees. This is a very important finding because babies who've got cardiac axis deviation is a very powerful marker of there being a congenital heart defect. So it is very important when you see this, especially in the first trimester, because this is a stronger marker than nuchal translucency or tricuspid regurgitation. or ductus venosus. In fact, it's stronger than all three of these combined. In this baby, like the patient we last scanned, the cardiothoracic ratio is increased. The normal cardiothoracic ratio is between 50 to 60. If you look at the SIêU guideline, it says 50 degrees. But I think up to 60 is okay. I only worry if it's greater than 60 degrees. But you can see subjectively with the eyeball, without needing to measure, that the baby has got cardiomegaly. Now you need to find the cause of the cardiomegaly. When you look, you see also that there is a pleural effusion, and this worries me. In this baby, it is very obvious there is a large cardiac tumor. Most babies with cardiac rhabdomyoma are multiple. This baby is also multiple. If you look carefully, you will see there's another rhabdomyoma here. And if you look carefully here, there's another one here. And if you look carefully here, there's another one here. Remember, once you see one rhabdomyoma, you need to look for more. And then there's a large pericardial effusion, and there is cardiomegaly. This baby, when you look at it, the descending aorta, the left atrium, the left ventricle. But when you look at the left ventricle, you appreciate, in a sense, the morphology is abnormal. You appreciate that the ventricles are switched. In this case here, you appreciate that the heart is located in the center of the chest, mesocardium. And when you look at the ventricles, you appreciate that the ventricles are switched. This is the right cardiac ventricle. This is the left ventricle, but the ventricles are switched. In this baby, you appreciate intracardiac echogenic foci, a common normal variation. Be careful, do not confuse these with cardiac rhabdomyoma. Finishing the fourth chamber with the rare changes, descending aorta, left atrium, left ventricle, which you have an atrial aneurysm. This is seen more commonly in the first trimester. And in this baby here, 13 weeks, with a dilated right atrium when compared to the left, and the baby who's got severe regurgitation, either related to Epstein's or tricuspidal dysplasia. And my last slide is remember to look behind the heart. This is a baby who has a common venous channel which is situated behind the left atrium. We could not demonstrate normal venous return with a hypoplastic left heart and total anomalous pulmonary venous return. This baby has got two vessels behind the heart. There should only be one. And this is in an uninterrupted IVC, a vasal discontinuation. This is a baby with three vessels behind the heart, with an azygous interruption, with an IVC continuation, and fluid in the esophagus. But if you wait, you will find that one of these fluid spaces, the fluid in the esophagus, will disappear. And this is the descending aorta showing vessels coming off to supply the lung. In a baby who's got a hypoplastic right heart with collaterals supplying the lungs. And you can appreciate this on a 4-chamber view evaluation of the heart. Next is what are the abnormalities that you will see in a 5-chamber. Normally, you see the interventricular septum is continuous with the aorta. 2, you look at the caliber of the aorta. And 3, you look at the aortic valve to make sure it disappears. In this case here, when you look at the 5-chamber view of heart, you see here there is a breach. It is not continuous. The continuity is lost. This is a perimembranous ventricular septal defect. You need to be very careful because with these babies, they may evolve into challenging or fallow as the pregnancy progresses. And when you scan them again later, it may look like the ovary is more marked. I cannot tell you which ones are going to evolve into fallows or which babies stay exactly the same with minimal override or no override, just a defect. because we don't have any way of crystal ball gazing to find out which will become fallows. So I can only say at this point that this is a perimembranous ventricular septal defect. But in this case, at 19 weeks, we have the interventricular septum, and now I can see that the aorta is sitting astride. This is a baby with a perimembranous ventricular septal defect related to tetralogy of fallow, or double outlet right ventricle, or common arterial trunk. I cannot tell you on a 5-chamber which of these three it is. It all depends on the pulmonary artery, and I need to look where the pulmonary artery is arising to work out the differential diagnosis. In this baby, when you look at the interventricular septum, the aorta comes more out of the right ventricle than the left. And this is a case of a double outlet right ventricle. Because this is the aorta, and 80% of the aorta is coming out of the right ventricle. And also the pulmonary artery is coming out of the right ventricle. This is a baby with the aortic override with a big vessel, and then it branches. This is the common arterial trunk, type 1. And this is the pulmonary artery, and this is the aorta. But you appreciate this on a 5-chamber view, but again, you need to work out where the pulmonary artery is coming from. Okay, so you go to work tomorrow morning, and you see this image. And you see there are two things which I do not like. Number one, when I look at the aortic valve, it does not disappear during ventricular systole. If I slow it down very, very slow, you see that the aortic valve, when it opens, that you can still see the valve, it is thickened. And the second thing is when you look at this, you appreciate that the aorta is narrow here, with a thick valve, and then it dilates here. This is showing color Doppler examination that shows turbulent flow, the yin-yang appearance of severe severe aortic stenosis. Many of these cases are missed because people do not look closely at the valve, or people do not look carefully for turbulence with the correct CRF setting. In this baby, when you look at the left ventricular outflow tract, it looks continuous. You see that the wall of the vessel is continuous with the interventricular septum, but there is a separate problem. This is the septum, and this is the wall of the vessel. But the vessel then bifurcates. This is abnormal. The vessel coming out of the left ventricle should never bifurcate. So this is a baby who on a 5-chamber view has got transposition of the great arteries, because the pulmonary artery is coming out of the left ventricle and the aorta is coming out of the right ventricle. This is a baby with a posterior malaligned VSD. You semi-loop and pause the frame and rewind. You can appreciate that the aorta is positioned in a posterior position when compared to the anterior wall. So it's displaced posteriorly. This is typical perimembranous VSD that you get with interrupted aortic arch, and it's called posterior malaligned VSD. And the aorta comes out of the heart in a straight line. The normal exit of the aorta should be curved. This is normal. Whereas babies with interruption, it is straight with a malaligned posterior VSD. In this baby on a 5-chamber with color, you see both arteries arrive in parallel. And in this baby, when you look at the 5-chamber view, you can appreciate that there are vessels coming off the aorta, which is coronary artery collaterals. This is a baby who's got a hypoplastic right heart. But it's on the left ventricular outflow tract view that you can appreciate these vessels. It's in the left ventricular outflow tract view that you appreciate transposed great arteries. The next section is the right ventricular outflow tract. This shows the sweep from a 4-chamber to showing the main pulmonary artery. And as you look at this here, is the pulmonary artery, and this is the arterial duct. This is, I showed you today in live scanning, this is the right pulmonary artery, the arterial duct, aorta, and SVC. This is the right pulmonary artery, left pulmonary artery, and there is no duct in view. Right pulmonary artery, left pulmonary artery, and the duct goes superior. When you look at this 3-vessel view, it looks abnormal. So this is the aorta, which is bigger than the pulmonary artery. Normally, the pulmonary artery is the biggest, then the aorta, and then the SVC. That's normal. This is abnormal, because the pulmonary artery is smaller than the aorta. In this baby, when you look at the pulmonary valve, you see this turbulent flow distal to the pulmonary valve. This is a baby with pulmonary valve stenosis. And most babies with pulmonary valve stenosis, the diagnosis is missed because you do not look carefully at the pulmonary valve with the correct Doppler settings. This is a baby with a 4-chamber view of heart at 13 weeks gestation. So you see here that this is a descending aorta, left atrium, left ventricle, right ventricle, right atrium. When you sweep from the 4-chamber up to the 3 vessels, you see both arteries arise from the right ventricle. And here are both arteries side by side coming out of the right cardiac ventricle. So we have here the main pulmonary artery and the aorta coming out of the right ventricle. This is 13 weeks in gestation with double outlet right ventricle. You can look with colour, however, and in this case slow flow, see that the vessels do not cross, they come out straight, parallel, out of the right ventricle. It is very important that when you do a scan at any weeks in gestation, that you do an examination showing the 4-chamber view of heart with the inflow on the 4-chamber, and then look for the 3-vessel tracheal view in the 3VST. You need to do this for every scan in the first trimester, is important, but also second trimester. When you look at this baby, you realize when you sweep to the 3-vessel tracheal view, there is only 2 vessels, which is the SVC and the aorta. You also note that normally the aorta, the direction the aorta comes out, this is the descending aorta, left ventricle, and this is the right ventricle. Normally the vessel coming out of the right ventricle should be convex to the left. This baby is convex to the right. This is called the boomerang sign, the reversed boomerang sign. And we first reported this in the White Journal back in 2013. We also reported on this finding at the mid-trimester with the reverse boomerang. So there are 2 things in transposition of the great arteries that are extremely helpful. 1, 2 vessels on the 3-vessel tracheal view. 2, the reverse boomerang sign. Both of those signs will allow you to detect the majority of babies with transposition of the great arteries. And the last section is the 3-vessel tracheal view. This is a very powerful section. I have shown you in live scanning today that the 3-vessel tracheal view looks like a V. This is the trachea and this is the SVC. I said to you that this should be always red. I said to you that this should always be blue. And I've looked here that this is the trachea, that the vessel close to the trachea is the transverse aortic arch, the arterial duct, and that is normal. When we look at this baby with the 3-vessel tracheal view, we see the sizes is abnormal. The size of the aorta, which is closest to the trachea, is smaller when compared to the size of the arterial duct. This is a typical appearance of a baby with coarctation, which is one of the most common outflow tract anomalies. But the simple observation of seeing the narrowed aorta sitting beside the trachea, and then you take a measurement and you do a Z-score measurement of the isthmus of the aorta throughout the state to check for arch growth. Now I ask you a question. Does this baby have left heart obstruction or right heart obstruction? You are all now experts. You know exactly what this baby has. Because you know that that's the trachea, and you know that this is red and this is blue, which tells you that there is normal forward flow in the aorta. But when you look at the arterial duct, there is reversal of flow. Therefore, this baby has got pulmonary atresia with intact ventricular septum, pulmonary stenosis, Epstein's, or tricuspid valve dysplasia. This baby is going to require prostaglandins at delivery. When you look at this baby, this is the trachea, this is the SVC, and this is reversible flow along the transverse aorta. This baby will have hypoplastic left heart syndrome, critical aortic stenosis, mitral atresia with VSD, or severe coarctation. So without even looking at the four-chamber view of heart, you can make the diagnosis. In this case, you see the trachea is in the center, and there is no V sign, but instead what you have is a U sign. This is the trachea situated centrally here, and you can see it splitting. This is the first semester scan, where this is the main pulmonary artery in the duct, and you can appreciate that the aorta splits into a right and a left branch. This is an example of a double aortic arch in the first semester. So this is a three-vessel tracheal view. We'll show these. Sometimes one of the branches may be atretic, and this is a double aortic arch with a left atretic branch on both stick and on rendered image. This is a baby with a three-vessel tracheal view. This is the trachea, this is the aorta, this is the duct, and then going behind the trachea is an average right subclavian artery at 20 weeks of gestation with a PRF set at 12 centimeters a second. This is at 12 weeks of gestation, showing the average right subclavian artery coming off as the fourth branch of the aorta, a feature that is associated with Down syndrome. In this baby is the trachea, transverse aorta, pulmonary artery, and this is the SVC. But the flow in this vessel is blue, the flow in this vessel is red. This baby has got anomalous pulmonary venous return because it has 1, 2, 3, 4 vessels, and the direction of flow on these two vessels is different. If the direction of flow is the same, it's a bilateral SVC. If it's reversed, it's total anomalous pulmonary venous return. This is a baby with 1, 2, 3, 4 vessels. There should never be a vessel beside the pulmonary artery, ever. I know it's the pulmonary artery because that's the trachea, that's the aorta, that's the pulmonary artery, and therefore there should be no vessel beside the pulmonary artery. In this baby, when you look on a four-chamber, you sweep up, there are only 2 vessels. A four-chamber, you can see there are 4 chambers, but there are only 2 vessels. So now you have to ask yourself, why? And the most common reason for seeing that with the boomerang sign is that baby's got transposition of the great arteries. In this baby, when you look, this is the descending aorta, the left atrium, the left ventricle. Now look at the right atrium, and you will see there is no flow from the right atrium into the right ventricle, because this baby has got tricuspid atresia. So if you look, you see flow from the left atrium to the left ventricle, but no flow across it. But the right ventricle is being filled through a VSD, and a vessel coming out of the right ventricle has got a reverse boomerang. This is the VSD, so the left ventricle is filling the right ventricle. So this is the baby with a complex cardiac abnormality. He's got tricuspid atresia, VSD and transposed great arteries at 13 weeks and 6 days of gestation. In this baby, you see a 4-chamber view of heart. Can somebody in the room tell me what is the abnormality? Tell me what is the problem with the 4-chamber view of the heart when you look at this baby? Anybody? Where is the aorta? Is the aorta on the left of the spine or the right of the spine? The aorta should be here, on the left of the spine. This is the left side, this is the right side, but the aorta is on the right side of the spine. Now watch what happens when you sweep from a 4-chamber up to a 3-vessel tracheal view. This is the trachea, the arterial duct, the pulmonary artery, the aorta, and the SVC are on the right. So this is a right aortic arch, right arterial duct. It is not a vascular ring, but it is associated with 22 Q's deletion. Remember, when you look at the 3-vessel tracheal view, you see in this baby that you have 1, 2, 3, 4 vessels, and when you sweep up high, the vessel that drains into the brachiocephalic vein. You go very high in the neck. This is the brachiocephalic vein. This is the thymus gland. The brachiocephalic vein is dilated. If you see a brachiocephalic vein that is dilated, you need to think of a vein of Galen aneurysm. Or you may see this also in severe growth restriction, where you've got increased venous return with a dilated brachiocephalic vein. So in summary, if you look at these sections, which I've gone through with you today, in each section you can pick up these abnormalities in routine screening of the heart. Thank you very much for your attention.